We've got a really interesting panel today. I'm just going to frame up with a few points as I invite our, and then we'll invite our speakers up to the panel here. We've all heard that phrase, "Trust me, I'm a doctor." We're not going to be talking about that kind of trust that's assumed and unearned. We're actually going to be talking about how trust is actually something we have to work on and not assume and earn. And I think you're going to hear that message come up time and again throughout this conversation. It becomes important, especially now, because we need more work on trust. It has always been the quiet force in global health. And what we have, I think, asserted just by virtue of the title is that trust is actually an essential infrastructure. When we think about buildings, and we think about medicines, and we think about health workers, we think about the software in an electronic health record or the smartphones that community health workers use as infrastructure. But trust is really the software infrastructure, if you want to call it, that percolates all of it. And so when that is there, as we've seen at the best times, it's essential. When it's lost, something we all experienced during the recent COVID-19 pandemic emergency, wherever you were in the world, it's a fault line that we are on that if tripped or broken or ruptures, leads to failure in delivering healthcare. So that's why we wanted to bring this to the forum agenda today and to engage with you in conversations. Today we're going to hear about how global health outcomes depend on whether communities are trusted, engaged, and empowered by health systems, but also whether those communities trust the systems that are trying to reach them. And we're also going to talk about drawing on innovations from change leaders, and you're going to hear from folks who are working in West Africa and in Latin America and in South Asia. We're going to hear from people around the world who are taking bold approaches and deriving practical lessons for building trust, not just one person at a time, but at scale. So I hope you'll come away with a couple things. One is all of us a deeper appreciation for why trust is an essential infrastructure like a hospital or an emergency room might be, but also how we might implement trust at scale, whether it's in healthcare if you're involved in healthcare, whether it's at work if you're not involved in healthcare, whether it's just in our lives, in our homes. So that's our hope and aspiration. And with that, I couldn't think of a better set of speakers to help guide us through the conversation. I'm going to call each of you to the front here, and you can just come up. We have Ari Johnson, and Ari, you can come up here and join me. Ari is a dear friend and is the CEO of Muso, and has just announced after many years of leading Muso will be stepping into a new role. He's also concurrently a physician at the University of California, San Francisco, and has just been extraordinary with his team at Muso in working in conflict-affected settings and trying both to bring trust to bear on the mission of reaching patients at the earliest point. As Ari, in their journey, as Ari often says, health cannot wait. And Ari, we look forward to hearing from you. Next, I'm going to invite Dr. Adana from Brazil to join us. And Dr. Adana Omágua Kambeba is a doctor and a shaman. She has an extraordinary biography, and I just want to read one line from this, if you don't know Dr. Adana, which I think will help you appreciate the perspective she'll bring to this panel. Dr. Adana is an indigenous physician, as she describes, from the Omágua Kambeba people, who are also known as people of the waters, whose presence extends across parts of the Amazon in Brazil, Peru, Colombia, and Ecuador. She was actually born in the state of Amazonas in Brazil and raised between indigenous and non-indigenous worlds. And she's been dedicated to building bridges between indigenous traditional medicine and contemporary biomedical science. So I think we look forward to your contributions as well. And Dr. Adana will be speaking not in the tongue of the forum, English, but we'll have translating services here on the devices, so we'll get a chance to hear you and throughout the discussion today. And last but not least, we have again, conflict-affected settings, settings of where indigenous wisdom meets biomedical science. And Piyush Tewari has bringing a different perspective from South Asia, where he has been the CEO of SaveLIFE Foundation. Piyush, please join us up here. Piyu is the founder and CEO of SaveLIFE. Many of you know it as the globally acclaimed nonprofit that's dedicated to preventing road crash fatalities. So something we almost take for granted in many parts of the world. And in India, where I've also spent a lot of time where Piyush lives, he has managed with his colleagues to secure India's landmark Good Samaritan law, which protects bystanders who assist injured victims. Imagine moments where we're called to trust one another. When you see a stranger get affected in a roadside accident, that it would intuitively either pulls you to act and work and try to help, or may push you to have a different direction because trust isn't already a given in that situation. So he actually found a way through this law to protect the bystanders who do assist injured victims, including make sure they're protected for any legal retaliation that can sometimes come up in those situations, and has gone on to redefine that approach, how other nations, including nations in the South Asian continent, take on injury and trauma care. So we have just a wide range of geographies, ways in which you all have engaged, and I think the best way to perhaps go through this conversation is really in three parts. First, I want to talk to you about why. What is at stake when we think about trust as infrastructure? Why does trust matter? And then I'd like to talk more about how we build it. And then I want to end with this conversation before we open up to Q&A. What needs to change in the way we fund and resource and invest in global health to make sure trust is part of the infrastructure in ways it hasn't been before? So we're going to start with that first part, which is what is at stake. And I'm going to ask this question. You can go in order here, starting with Ari, you closest to me. But I want you each to think about and give us your thoughts on this. Give us a moment from your work, your experience, you realized trust was broken. And tell us what became possible when that trust was rebuilt.
Thanks, Raj. Thanks to everyone for being here for this conversation. So 20 years ago, I was living along with Muso's Malian and American co-founders in the shadows of Mali's capital city in Bamako. And one of my neighbors came to me, and he was totally panicked. He was carrying his 9-year-old son, and his son had just lost consciousness. He was in a coma. And so we rushed him together to the hospital where he was diagnosed with AIDS and cryptococcal meningitis. And by the time we got him on treatment, it was too late. And I remember sitting with him, with his parents, my neighbor, my friend, at bedside, praying for him to wake up and watching him die. And as we sat vigil together, I started talking with my neighbor, my friend, and hearing about his son's story and understanding that his son had been sick for a very, very long time. And we're not talking about days, we're talking about years. And I learned about how his family felt they'd been betrayed, that how the healthcare system had betrayed their trust. And in the days and weeks that followed, my other co-founders and I, who are living in the communities we served, Malian and American, we ended up attending the funerals of our friends, our neighbors, our mentors, nearly every week. Especially young moms, kids, babies, all because they weren't getting the care they needed in time. And when we asked an array of officials, smart people, experts in the field, we got told again and again that this is happening. Our patients were getting care late. They mistrusted the health system because of ignorance, because of a lack of education. So we were encouraged to pursue changes in knowledge, attitudes, practices. We were encouraged to pursue behavior change. An implicit idea that our patients were maybe misbehaving or they're non-compliant or non-adherent. But rather than lecturing, we decided to listen. We sat down with patients and asked them to tell us their entire life stories. And then we also walked with patients, first a few, then a few dozen, then hundreds of patients, one at a time, to see the healthcare system through their eyes. And as we did so, we learned something that really astounded us, that our patients' mistrust had nothing to do with their ignorance. Their mistrust was their expertise. It was something that we had to learn from.
Their mistrust was expertise.
Yes, because they weren't mistrusting the healthcare system because they were stupid. They were mistrusting the healthcare system because they were smart. They were sitting in their homes with their sick child and seeing the healthcare system in front of them like master chess players, seeing what would happen 3 steps ahead and focusing their decisions with an intensity of analysis like their lives depended on it, because their lives did depend on it. And in the process, they explained to us why they didn't trust the healthcare system in front of them. They told us about the fees they couldn't afford to pay, the distance they couldn't afford to travel, the providers without the skills or the stuff to make the diagnosis or provide the cure. And so in doing so, they handed us the blueprints for a different kind of healthcare system. Removing out-of-pocket fees, meeting patients where they are, the professional community health workers from the communities they serve, who bring diagnostics and therapeutics door to door, redesigned, upgraded primary care clinics. Our patients showed us this vision of the kind of healthcare system that would be worthy of their trust. And so when we built that, the results were astonishing. Our research showed an immediate 10-fold increase in patient visits. There was no convincing needed. We didn't need
People wanted to come to care rather than
waiting.
Tenfold increase in visits.
Immediately.
Yeah.
There was no convincing needed.
Yeah.
And these communities that once had among the highest rates of child death in the world, within a few years had achieved child survival rates on par with the United States. So today, a child born in the communities we partner with has the same chance of surviving as my own kids born in the US. And that is the potential before us when we design healthcare systems with community members and when we design health systems that are worthy of patients' trust.
You've really taken, it does, it sure does. You are a professor, and I'm struck by what you just said, that their mistrust is their expertise. I think I've heard you sometimes say that our patients are our professors. Can you tell us more about, I think all of us wish those who are considered experts or have conventional power or authority as we're socialized to imagine them to have, be they a government official, a healthcare provider, a business leader, an organizational leader. We all wish people could show up with that kind of humility in our lives, especially when there's such a power differential. In this case, someone depending on you, knowing their life depends on the medical system, and yet wanting to be accompanied and appreciating that they may mistrust that very system because it's failed them before. You mentioned the young boy that you had to be at the bedside for, and it was too late by the time you got to them. Can you tell us where that comes from? Your own, like, what is that something that just Ari was born with, or does Ari have a personal practice that allows you to be that way? It's remarkable to have a professor at one of our most distinguished universities on earth say, my patients are my professor, but then to walk the talk, as you just shown you and Muso have done.
Yeah, well, that's a shared commitment amongst our team, that our patients are our professors, that we have to learn from our patients. And They're also our bosses. They're folks to whom we're ultimately accountable to. I learned that from one of my co-founders. Her name is Nana Nyare, and my daughter, Maya Nana, is named after her. And Nana did something quite radical and profound herself when she met this group of young Malian and American doctors and medical students who wanted to be helpful. She was a matriarch of this community, and rather than this community had seen many people come and go, do launch events and abandon many broken and failed development projects. But in response to that short-termism that had caused so much skepticism and mistrust, she went the opposite direction. She doubled down on commitment. She said, why don't you all come and move in with us? Why don't you actually come live in or near my home? And my home will be your home. My family will be your family for the rest of my life and beyond.
Yeah.
I mean, I try to imagine, could I ever make such a profound commitment to another human being? And in doing so, she set the tone and changed everything that came after, because our patients, the folks we wanted to serve, became our neighbors, became our friends. And that positioned me in a different way. And then Nana herself, people would come to her. She was a retired nurse. People would come to her for advice and help in difficult moments. And Nana's way, she would sit, she would listen to them, and she would honor them. And she invited us to come and sit with her and listen to our neighbors. And so it was from her that we learned that we need to start, we need to go in listening. And this is not an idea that is, I think, reserved for healthcare even. This is something that we can apply in any domain where we need to earn trust. Jessica Livingston, who co-founded Y Combinator and made her wealth by seeding some of the world's most successful tech companies, said, all right, this Apple idea of think different, well, divergent thinking isn't always good. There's lots of ways to think different that don't result in meaningful change. But the most successful companies, when they're asked to choose between the common way of doing things and making those they serve, their patients, in this case, their users, happy, they choose their users all the time, even when it's hard. That's the kind of thinking different that we need. And we're living in an age of mistrust, and if we can respond to mistrust with curiosity, by assuming the person who mistrusts us has something to teach us, I think something very profound can happen.
That's a great point. It's a great point. Thank you for that, Ari. Dr. Adana, I want to come to you next. Again, if I could ask you, and some of us will take a moment to put our headsets on, what was a moment you realized trust was broken, and what became possible when trust was rebuilt?
Eu tenho vários episódios para poder compartilhar aqui. Mas muito desde cedo eu percebi realmente essa quebra da confiança desde a minha infância. Porque é uma realidade nossa na Amazônia, de muitos nós indígenas, não temos ainda aquele acesso aos médicos biomédicos da medicina ocidental. Então, os nossos rezadores, os nossos pajés, os nossos curandeiros são os nossos especialistas tradicionais. E muitas vezes nossos pais e avós não confiam nos médicos. Confiam muito mais nos rezadores, nos pajés, nos curandeiros, do que nos médicos. E só leva no sistema de saúde médico, biomédico, quando realmente não tem mais jeito. Eles não confiam. Então eu cresci vendo isso e eu achava estranho. E quando tinha algo, meu pai e minha mãe me levavam para o rezador e sempre tinha todos os rituais para a gente poder ter acesso a esse tratamento. Quando eu fui fazer medicina numa conceituada universidade no Brasil, uma das 5 melhores, foi realmente para mim um impacto. A maneira como eles focam e veem o ser humano. Na verdade, o tratamento é focado nas doenças. É um modelo bem cartesiano, totalmente diferente daquele que eu aprendi com os meus avós, com os anciãos. Eu tive que levar alguns anos para assimilar e tentar encontrar essa relação. Ali eu vi a confiança sendo quebrada. A medicina tradicional indígena e a medicina científica oficial, elas não conseguem ainda se escutar, dialogar. Inclusive, existe uma relação de poder, onde a medicina ocidental, ela está institucionalizada, está de certa forma legalizada, enquanto o conhecimento das medicinas tradicionais ainda continua sendo muito marginalizado, muito invalidado, como se precisássemos de validação. Eu fui percebendo que os dois sistemas são duas estruturas únicas, diferentes e totalmente legítimas. Não precisaria de validação, não precisa desse campo, dessa oposição. Ambas podem dialogar. E eu recebi essa, não sei se digo essa missão, que foi passada de ancestralidades. Minha avó, Kambeba, antes de partir, ela havia me falado isso, que eu haveria de continuar os que os meus avós haviam iniciado, e meus bisavós e tataravós. E eu disse, mas vó, como vou fazer isso? Vou fazer medicina, biomedicina científica, como vou fazer isso e unir esse conhecimento tradicional? Não sei, minha filha, só sei que é você. E aí eu fui seguindo esse caminho. E aconteceu realmente experiências muito espirituais que foram me mostrando que era possível. Ao ponto de ter que conseguir esse diálogo acontecer. Resumidamente falando, para poder atuar com essa complexidade de restabelecer a confiança das duas medicinas, primeiro ela precisou ser trabalhada dentro de mim. A confiança precisou ser trabalhada dentro de mim. Eu tive que encontrar esse diálogo dentro de mim para poder mostrar aos outros como fazer. Ao ponto de ser chamada, tanto em postos de saúde como em hospitais, para interceder entre a medicina científica oficial e entre a medicina tradicional indígena. Situações de confronto, onde precisávamos de resultados, inclusive situações de vida e morte, onde os médicos não estavam se entendendo com os pajés e o paciente estava precisando de uma resposta para ontem. E agora o que vamos fazer? Nós temos que aplicar protocolos médicos, precisamos disso. E os pajés e as famílias indígenas, não confiamos no seu sistema, não queremos assim. Primeiro temos que ter nossos rezos, nossas orações, nosso tratamento. Foi algo assim tão complexo, tão desafiante, ao ponto de eles tentarem encontrar recursos de como ajudar. E era uma situação que eu posso comentar aqui de vários episódios que eu vivi, uma que me chamou muito a atenção profundamente, e ali eu vi a restauração da confiança em uma situação que uma mãe, com seu recém-nascido, com 4 ou 5 dias de vida, parou numa CTI neonatal, com sepse presumida neonatal. E os médicos falaram, nós vamos precisar entrar com protocolo, entubar a criança. Os pais se assustaram. Isso não existe na nossa cultura. O que é isso? Vocês vão fazer o quê? Tirar sangue da nossa criança? Isso não existe na nossa cultura. O que significa isso? Vocês vão tirar o quê dela? A energia da nossa criança? Eles não estavam entendendo. Os médicos não sabiam explicar e estavam desesperados. Ao ponto da mãe dizer assim, ninguém chega perto de meu filho. E o pai, que é pajé, nessa hora, não sabia mais do que lidar com a situação. E aí, quando chegou a enfermeira e assistente social, ela não deixou ninguém se aproximar, ela pegou as sandálias e começou a jogar nas pessoas dentro da CTI. Não deu ninguém se aproximar. Aí falaram, chama a Adana. Chama a Adana. Porque os médicos vão escutá-la. E o pajé também vai escutá-la. E eu lembro que eu estava no 2º ciclo da minha dieta de pajé, que é uma dieta rigorosíssima. Eu estava com 39 quilos. bem debilitada, bem fraquinha. Quando eu ia dar minha primeira... Estava no horário do almoço, quando eu ia comer, ligaram do hospital. Adana, pelo amor de Deus, venha para cá. Estamos com uma criança, vamos perdê-la, não conseguimos entrar em ação. Os pais não deixam, os pais são indígenas, não entendem. E os médicos precisam entubar a criança. Vem para cá, por favor. Aí eu larguei a comida e fui para lá, orando, rezando a tupana, Deus, para me ajudar, poder ser essa diplomata, intercessora desses dois mundos. Cheguei lá, dentro de uma CTI, neonatal, o clima já estava tenso. Cheguei, a mãe me viu, se emocionou, se aproximou de mim, explicou por que não queria. Por que não queria aquilo. E não entendia por que tinha que entubar. Os médicos se aproximaram e disseram que aqui está o prontuário, doutora. Essa situação, o que vamos fazer? Aí eu recebi, eu falei, preciso conversar com o pai e com a mãe a sós. Conversei, nosso jeito indígena, simples de falar. Ela ouviu e eu também a escutei. Quando eu a escutei, eu a abracei e disse, isso que acontece, eu vou fazer rezo, vou orar. Então ela disse, então eu aceito, eu recebo, eu confio em você, doutora, eu confio no seu rezo. E assim aconteceu. Fui ao médico, os colegas e disse, ele aceitou, ela concorda, vamos entubar a criança. Entubaram a criança e os pais confiaram em mim. E eu sempre ia lá na CTI neonatal fazer rezo, do nosso jeito indígena. E mediante a isso, eu ia lá todo o tempo fazer isso, e acompanhando. Então usamos medicina tradicional indígena e medicina científica oficial. Depois de alguns dias, estava ela muito feliz com a sua criança no colo. E foi salva. O pai e a mãe disse para a antropóloga, aquela doutora, ela rezou, olha, rezou, ela salvou nosso bebê. Para o médico falou, não, isso foi um antibiótico. Mas não importa se foi antibiótico, se foi rezo, o importante é que nós salvamos uma vida. E a confiança se restabeleceu. Eles aceitaram que fosse entubado. Eles aceitaram o procedimento. E o hospital acolheu. Isso é importante. Isso é um exemplo de como é possível restabelecer a confiança. Diálogo das duas medicinas.
That's such a profound, deeply profound example. Thanks. First of all, thank you for showing up as you did for that family, and as you say, a diplomat bridging both worlds. I can't imagine. I mean, to almost lose a newborn, and then to, again, as Ari mentioned, you know, the wisdom of being skeptical, because for that family it sounded like even if you would have trusted the antibiotics for the sepsis for that newborn, they wouldn't have felt like it was an experience that they'd feel safe in, because it was taking blood from a newborn, which, as you noted, was something that sounded completely against anything they'd ever been taught. So thank you for just being there and sharing, bringing us into that family's moment. I'm curious, what do you think that family, the impact of that experience with you, that family presumably went back to wherever they were living, either with that family, if you've kept in touch with them, or with others, what impact do you perceive that has had? What story do you think they're telling their neighbors about that experience?
O que aconteceu foi algo que se expandiu para dentro do território de onde eles estavam morando. Eles são do povo Uarau, da Venezuela. Situação muito delicada politicamente lá. Então, muitas famílias do povo Uarau estão indo para o Brasil, morando no Brasil. Inclusive, está sendo questionado e tentando construir políticas públicas para auxiliar essas famílias, porque a maioria não fala a língua portuguesa. Então, precisamos, às vezes, de tradutores. E foi o que aconteceu. Então, eles chegarem num país que eles não sabem a língua, eles já se sentem, de certa forma, violentados, eles já têm experiências de violências na área da saúde lá na região. Então, quando eles viram que foi restabelecido, que eles viram que sua medicina tradicional foi estabelecida, isso trouxe a eles uma grande oportunidade de ver sua dignidade humana sendo respeitada. Nós indígenas, no geral, seja no Brasil, Venezuela, qualquer lugar do planeta, nós temos histórias muito difíceis, de muita marginalização, de muita discriminação. Você chegar num sistema de saúde onde os médicos podem respeitar, podem entender e escutar a sua maneira de tradição, que já é ancestral de muito tempo, isso é algo assim de uma transcendência que mais que a gente tente encontrar palavras, a gente não saberia encontrar uma palavra que pudesse ficar à altura do que eles sentiram. E eles puderam passar também a essas famílias. Isso traz um alento, um alívio, de uma esperança de que é possível suas medicinas serem também respeitadas. Vejam só, eu fui para dentro de uma CTI neonatal fazer rezo indígena, cantar, levar o instrumento lá dentro. Recebi o apelido da enfermagem de pajé neonatal. Eu falei assim, ela poderia logo fazer rezo em todos esses neonatal para todos irem para casa já, né? Ela só faz nesse, ela fez nesse e esse já saiu. Podia fazer nos outros também. Então isso é algo assim.
Did you do that? Did you end up? Did people ask you?
Oh?
Did people ask you to do that, to sing for the other babies, even if they weren't that family?
As enfermeiras que sempre estão em plantão, elas falaram: "Não, tá vindo uma pajé aqui fazer rezo num recém-nascido e ele já saiu. Então, ela é a pajé neonatal, chama ela para logo rezar em todas essas crianças, para essas crianças todas receberem alta." Foi muito engraçado. Mas é porque era a família indígena que estava lá. Eles acreditam no rezo.
Yeah.
Né? Então, eu também fiz o rezo na mãe e também no pai. Quando se trata um paciente, se trata a família toda. A depender de cada situação de saúde. Pode ser, inclusive, fazer até mesmo o tratamento com a ayahuasca. Mas depende muito de cada situação. Isso realmente é um desafio.
I want to ask you one more follow-up. You describe the importance of I think what some psychologists would call dialogic control, where you still focus on, in the middle of a crisis, a common aim, in this case, healing for this baby, safety for this baby. And yet you gave permission and enabled both the biomedical nurses in the NICU, in the neonatal intensive care unit, and this family to be able to hold on to their basic belief systems about how healing and safety occur in one's life. I mean, it's extraordinary, first of all. And second, I wanted to ask you, I mean, you seem to have, even in your other work, your broader work in changing systems around this, ability to hold both of those ideas in tension. And where I come from, we call that pluralism. In fact, we created an entire country in the United States that says out of many comes one, e pluribus unum, which builds on the fundamental idea that two ideas or multiple ideas could be competing with each other, and yet something from that tension could be created instead of destroyed. I mean, you just gave a beautiful example of how pluralism could be applied in indigenous and biomedical intervention. Where does that come from for you? Like, what is there a personal practice you use to maintain that? Is there a life experience? You mentioned this figure in your life who said, no one's ever done this, but you're going to be the one. Was that what shaped you, or what was it that gave you that worldview of indigenous and biomedical medicine could be both held together, and out of that something beautiful could happen instead of something destructive?
essa é uma necessidade constante dentro da realidade amazônica. Porque os sistemas de saúde, quando chegam nas comunidades, muitas vezes já chegam levando solução, sem escutar as comunidades. E esquecem que antes da chegada deles, o cuidado já acontecia há muitos anos. E acabam desconsiderando um cuidado já pré-existente. E eu fui percebendo isso. Então, desde criança, eu já cuidava de animais, de plantas e de pessoas, criança. Ao média de uns 8 a 9 anos de idade, eu dava conselhos para pessoas mais velhas, cuidar para até meus avós. Eles vinham até mim pedir orientação. Minha família via isso e dizia, isso não é comum. A minha avó indígena, que assumiu a origem comigo, ela olhava assim, isso são sinais. Quando cheguei na adolescência, ela me revelou que na nossa linhagem de pajés, de curandeiros, a religião cristã havia feito a ruptura. Por isso que o meu avô, que tinha casa de rezo, recebia as pessoas para fazer tratamento, ele parou e foi aceitar Jesus. A igreja, a Bíblia debaixo do braço. E a minha avó falou, você vai dar continuidade para aquilo que foi ali atrás, ruptura. Foi quando eu disse, mas vó, como vou fazer isso? Eu ainda vou fazer medicina científica, como vou ir pajé e... Não sei, minha filha, só sei que é você. E foi quando eu entrei na faculdade médica e eu levei um susto com aquilo que eu vi. Uma medicina cartesiana, cética, focada em doença e não em pessoas. E agora o que eu vou fazer? Quando eu estava nos últimos anos da faculdade médica, foi quando eu disse assim, eu não aguento mais. Porque eu estava sofrendo preconceito. Eu era a única aluna indígena de um curso da medicina, eu estava sendo uma das únicas. E a maioria, outra realidade. E eu cheguei um momento que eu disse no meu plantão, eu falei, eu não aguento mais, eu não vou conseguir. Eu já sei, eu vou fazer só medicina biomédica, científica. Isso de pajé eu vou deixar de lado. Não vou mais fazer isso não. E ainda fazer as duas e depois provocar o diálogo das duas? Nossa, isso é muita responsabilidade, não quero isso para mim não. Chega. Eu tinha tomado uma decisão que eu não ia mais querer, porque estava muito com um cansaço de alma, fora de todo o meu normal. Eu nunca tinha sentido aquilo. Foi quando apareceu algo sobrenatural. Eu não quero ficar dentro muito detalhe, mas que dentro da psiquiatria, diria que eu estava tendo uma alucinação auditiva, ou talvez é uma alucinação visual, mas esse ser conversou comigo. E eu duvidei da minha... Eu estava muito cética, eu estava duvidando da minha sanidade mental. E eu conversei com esse ser, eu disse assim, eu não acredito nisso. Eu não aguento mais. Você está perdendo a sua fé? O que é preciso para você voltar a ter fé? Vai acontecer assim, assim e assim. E aí você vai acreditar que é a sua missão? Aí eu falei, agora vou acreditar. Aí eu vou dormir. O que eu estou fazendo? Eu estou conversando. Nossa, eu estou ficando louca. Eu estou perdendo minha sanidade mental. Eu devo estar muito cansada. Não, vai dormir. Eu fui dormir. No dia seguinte, tocou ali o alarme que era para ir para fazer plantão. E no dia seguinte, no plantão, aconteceu tudo o que a voz tinha dito. Tudo. Eu disse, não, eu não tive uma alucinação auditiva. Isso é real. E aquilo, para mim, foi um grande trunfo na minha vida de falar assim, é isso. Foi quando eu senti a realidade de mim falando, nunca mais duvide da sua missão. Você vai fazer isso acontecer. Você vai fazer medicina científica oficial e depois a medicina tradicional indígena e vai provocar o diálogo das duas. E você vai ser a primeira a fazer isso no Brasil. Nunca mais perca fé em você. Aí, fui com tudo. Já fiz 8 anos de dieta. Estou aqui firme e forte e estudando bastante até hoje.
Well, my grandmother has superpowers too. That's a pretty awesome grandma that you have. Thank you for that. Piyush, I want to turn to you. We're moving from Latin America over to, from the Amazonas to South Asia. Same question to you. Tell us about a moment where you realized that trust was broken and what was possible when trust was rebuilt.
Sure. Thanks so much, Raj, and thanks everyone for being here. I still remember on 5th April 2007 receiving a call from my father about my little cousin Shivam meeting with a very serious crash. By the time we sort of got done with that conversation, and a few minutes after that I received another call from him saying that Shivam had passed away. What I eventually learned was that it wasn't just the crash that killed him. It was something much beyond that had happened. So this was 3:30 in the afternoon. He was on his way back from school. At one point, he tried to cross the road and was struck by a vehicle, eventually run over by the vehicle. And despite his injuries, he was able to drag himself to the side of the road. There was a tree, and he sat there with his head to the tree, asking passers-by for help. As I'm told, a large number of people stopped to see what was going on. Some people offered him water to drink. Some people threw water at him so he would remain awake. But no one did anything that could save his life. No one called the police, no one called the ambulance, and no one rushed him to a hospital. So after waiting for about 40-45 minutes, this young 16-year-old boy in his school uniform, white shirt, blue trousers, black shoes, had bled to death on the side of the road. So the first reaction obviously was of disbelief, anger, and assuming the worst of the human condition. So obviously in my head, it was unacceptable that we could allow even animal, to die like that. Forget about a fellow human being. And so the first assumption was that this was apathy that had killed him, that people just didn't care. Of course, system was fractured, the formal emergency services system, but it was the people who failed him. That was my first impression. But something didn't sit entirely well with me, because obviously this was a massive loss for the family, and I wanted to dig deeper into what was going on. And I was so shaken that I took time off from work and I traveled across the country. I met with doctors, lawyers, police officers, other victims' families to try and get some answers. And what I fundamentally learned in that process was that it wasn't apathy that killed him. It was a very profound fear and mistrust of the system or the conditions that would follow the act of helping someone that made people hesitant to come forward and provide help. As I dug deeper, I started to realize that this wasn't an isolated case. nearly 50% of people who were dying on the roads in India were dying despite having treatable injuries, simply because people were too hesitant to even make that call, because traditionally the act of helping someone has been followed by police scrutiny, lengthy legal cases, and so on. And for people like us who are privileged, it might still be okay. But for the person who's working along the road, who's more likely to see these situations, for a person who's not as privileged or protected, it was a very significant impediment to do that most basic human thing of helping another person who was injured. So that's fundamentally what became the premise on which SaveLIFE Foundation was established, and to tackle that issue, I started to try and find answers to what how do we solve this. And the government would say, we should do more awareness, we should get people to become more empathetic, we should train people to help, And what I very quickly realized was that a training will provide the skill, but it can't provide the confidence if somebody has a fear or a mistrust attached to that situation. Awareness, in my view, and I'll talk a little bit more about that later, but it's mostly a surface level intervention when nothing else is structurally possible. So that's how it became clear to me that what we had to attack was this fear and mistrust. And the solution for that became trying to get India its first ever Good Samaritan law that would insulate people from any kind of legal procedural hassles if they step forward to help an injured person on the road. This was going to be a very significant criminal justice reform, because a road crash in India is treated not as a civil matter, it's treated as a criminal matter. And therefore police has sweeping powers to detain people, to question people, to call them again and again to the courts and to the police stations, and subject them to what could amount to harassment. But it was very clear that that's what we needed. And so in 2012, I moved the Supreme Court of India, stating that what was going on was a violation of our right to life and liberty, and that we needed to intervene by getting India a Good Samaritan law. There was massive opposition from the government because we were talking about reducing police powers, reducing their powers to do what they were used to doing. But we soon expanded that advocacy from Supreme Court to the Parliament of India, to media, and so on and so forth. And thankfully, on 30th of September 2016, we were able to secure, through the Supreme Court of India, a nationwide binding Good Samaritan law that protected and insulated anyone who would come forward to help an injured person on the road. So that was the process, in my view, of doing something to build trust. But policy alone doesn't build trust. It's the implementation of policy that builds trust. So the last decade we have spent in getting the policy implemented, in ensuring that people understand what their new right looks like. Because even despite the policy, there was still mistrust. That fine, there is a Good Samaritan law, but if I go ahead and help someone, what if I'm still harassed? Who's going to save me? Will I have to go back to the court? Do I have the resources for that? So we've been working on that piece to build trust. Now, in 2013, when we started this exercise, we conducted a nationwide survey to understand how many people would help an injured person on the road. And 3 out of 4 people said that they would not, because of fear. In 2024, we conducted the same survey again. And there, 2 out of 4 people agreed to help. So from 25%, it's gone to 50%. So that's where we are today, which is great because we don't want everyone to be a rescuer, but you have that one person. You have that one person who will make that call, who will provide the assistance, who might rush the person to hospital. That's what we need. So we are still hoping to reach a stage where we have more people than not who are willing to help. But the core aspect has been to attack the issue of trust, not from an awareness or a skill or a obligation standpoint, but more from a structural, systemic standpoint, which is to treat it like infrastructure, that it's solvable, it's buildable, and something that we can invest in over a period of time to see things change.
It's such a great reminder of the idea that trust really is shaped by context, by power, by systems. You've gotten us started on the next part of the conversation, which is about how trust in your work plays out now, and who do you work with to build it, and what are you doing now? Anything you want to expand upon? You were already covering some of that, but anything just give you a chance to expand before we go back this way towards me.
Sure. So I think the
Have
key.
you been surprised by that result? Have you been surprised by the doubling?
I wasn't surprised, primarily because we had come to believe, after speaking to the community, after speaking to people, that it was not the lack of skill or awareness that was the impediment, or it wasn't apathy, but it was really the mistrust and the fear that had to be tackled. And it was only when you tackled it at the structural level that we could rebuild that. So I was pleased. I was pleased that it took 8 years for something that had been a practice for 60, 70 years to change and to improve significantly, but not so dramatically surprised as such. Yeah. But the point that I wanted to make was, and I was thinking about this conversation as I was having lunch today, and the one thing that I realized is that we oftentimes treat trust to be relational between people, right? And if trust is relational, then and it's between people, then how do you scale that? How do you take that to the next level, right? How do you scale that to a population level, right? But the moment you start seeing trust as something that is systemic, that can be assessed, that can be diagnosed, that can be evaluated, audited, it's something that becomes solvable. And the approach that we took in the early years with the Good Samaritan law was to really look at it from a structural perspective, but at the heart of it, keep the community as as Ari mentioned as well, that as he mentioned that you learn from the patients. We learned from the community in terms of what that solution would look like, what the slivers of the problem were, right? What were the structural changes that were required? Something as simple as if a policeman in India, in uniform, arrived at your home, even if you're a Good Samaritan, to take your statement, the neighbors would think that you are in trouble. It would cause a social, sort of a stigma that there is police coming to your house, right? So we had to change that. We had to say the policeman can still go, but they have to go in plain uniform, in plain clothes. They can't go in uniform, so that stigma could be addressed. So we started looking at it both empirically, behaviorally, as well as from a structural standpoint, that we could address each of those specific issues that the community had, that the people had, that were leading to mistrust, and solve for them specifically. So when you read the law, of course, the top line says everybody should be protected, but what does that really translate into, right? How many court appearances? Can you say that, okay, my job, after making that call or after rushing a person to hospital is over? You know, do you have that right? And that you don't want to be involved any further, right? So we had to really get into the depths of that, because if you want to rebuild trust of something that you know, has taken 60, 70 years of you know, sort of disincentive to sort of not be there, you have to really target at that structural level. And that's really what sort of the core learning was from our end at that point of time. So it's not relational, it's mostly structural, and it can be built over a period and can be scaled.
The word community, I recently just been looking into this. It comes from, one of its roots is the word munis, which means shared responsibility. And so community literally is shared responsibility to one another. You think about the cities you work in, the municipalities you work in, where that word, the same root comes from. It's striking and puts, you know, that in many ways we intuitively understand and have come up with words like community or municipality that mean shared responsibility. And it makes a lot of sense that if you then would lose trust or be broken in the context of one driver running into you know, someone walking across the road and the painful experience of your own relative, that one could rely back again on that core idea of shared responsibility to one another as a way to reach a new level of trust. And you've actually been able to measure it, which I think is remarkable. I want to come back to you, Dr. Adana. Could you tell us, in your work, what does trust look like now? Whom and how, with whom do you build it, and how do you build it?
Essa confiança, ela é construída de maneira coletiva. Nada é feito sozinho. Realmente nós, profissionais de saúde, somos aprendizes. São realmente nossos pacientes que são os nossos grandes professores. E são as comunidades que nos ensinam como realmente as coisas precisam ser realmente feitas. Na Amazônia, por exemplo, muitas comunidades já têm os seus cuidadores. Então, quando o sistema de saúde chega nas comunidades, tem que chegar predisposto a escutar e não achar que é o dono absoluto da solução. E eu não estou falando apenas de infraestrutura no sentido tecnológico ou protocolos técnicos de saúde. Eu estou falando realmente estabelecer a confiança que ela é construída com o tempo. Não é só chegar lá e fazer um trabalho pontual. É chegar, escutar, sinceramente, trazer a comunidade nas decisões, inclusive nas decisões relacionadas ao tratamento e aos cuidados com seus próprios corpos, para que eles possam também sentir essa autonomia, se sentirem vistos, se sentirem presentes, respeitados. Eu percebo que isso, numa área de saúde, no caso dentro das comunidades indígenas, ainda se consegue fazer isso com uma certa facilidade, a depender da equipe multiprofissional que está indo para lá. Existem equipes com a mente muito aberta e muito predisposta a construir junto com a comunidade. Agora, quando se trata em fazer isso dentro de hospitais, aí é mais difícil. Dentro dos hospitais já existe toda uma estrutura. E você tentar fazer essa confiança nascer, crescer, desenvolver dentro de um ambiente hospitalar é mais difícil. Eu lembro de uma experiência que tive em uma maternidade, que é considerada uma maternidade referência em partos normais, partos naturais, chamado Hospital Sofia Feldman, que fica em Belo Horizonte, Minas Gerais. É um hospital referência, já se ouvi até documentários a respeito, uma referência na América Latina. E lá eles atendem mulheres de todas as situações, de todas as origens. Então, o que nós vimos um certo despreparo dos profissionais quando estava se tratando de indígenas, mulheres indígenas, cada um com sua cultura, sua língua, sua alimentação. Então, eles não sabiam muito bem como lidar. Então, o que aconteceu? Eu entrei em contato com a diretoria do hospital e nós conseguimos fazer como se fosse um espaço, um momento de abertura, de capacitação para os profissionais de saúde, médicos e enfermeiros, para que eles pudessem ter um contato com esse mundo indígena. Primeiro apresentar, porque não adianta falar, vai ali e escuta. Não vai escutar, vai lá e escuta. Escutar o que? Eu não sei nem como é que é a cultura. Então venha conosco, vamos mostrar. Quem mostrava para eles? Chamei várias mulheres indígenas, de várias etnias, para poder estar junto com os médicos e enfermeiros num grande encontro de capacitação, onde elas puderam fazer trocas e dinâmicas e falar a respeito. Aí os médicos e enfermeiros começaram a entender um pouco mais. Ah, então é assim. Então começou a criar um cuidado mais a respeito disso. Primeiro tem que apresentar, para depois construir. Dentro de um ambiente hospitalar. Aí fomos um pouco mais adiante, porque eu não paro, não sou quieta. Lá fui atrás da onde? Do DICEI. O DICEI é um distrito sanitário de saúde indígena, de saneamento indígena. Existem 34 DICEIs que são responsáveis pela questão da saúde indígena no Brasil. Então, existe a coordenação de cada DICEI. Eu fui com a coordenação do DICEI de 2 estados, de Minas Gerais e Espírito Santo, trouxe para uma reunião junto com a diretoria do hospital para que pudéssemos fazer implementações dentro da realidade específica da cultura indígena, para que pudessem fazer salas próprias para poder atender as mulheres indígenas. Por exemplo, a maioria das mulheres indígenas, elas dormem em rede e não em cama. Então, o hospital teria que ter redes. A alimentação também é a nossa macaxeira, que chamam também de mandioca, é o peixe, são nossas bananas. Então, tem que ser de acordo com a alimentação. Porque para elas, quando elas estão perto de dar à luz, tem uma alimentação específica. Elas não querem comer a comida que o hospital serve, elas querem comer dentro da alimentação delas. Então, esse foi o objetivo de ter trazido a coordenação do DICEI junto com a coordenação desse hospital maternidade, para poder se fazer essa construção. E antes de eu sair de lá, eu deixei isso já encaminhado, eu falei, eu vou precisar assumir uma outra missão, porque eu não sou quieta, né? Não paro. Aí eu fui fazer uma outra missão, que é essa missão que eu estou lá com o meu povo no Amazonas, que é uma outra ação que eu estou fazendo, mas deixei encaminhado para que o hospital e o DICEI, que é esse distrito sanitário de saneamento indígena, pudesse já dar alguma continuidade nessa adaptação dentro do hospital. Então, assim que se faz as construções.
That's beautiful. You know, it's striking to me that finding common ground and doing that face to face is such an important part of what you just talked about. And to do that prior to when trust is most at stake, like in a crisis. And just think about the newborn who was ill, the encounter you described earlier. Can you, this idea of building trust, as we could have just taken out the words global health, and you could have done an entire session, we could have done an entire session as trust as human infrastructure, just infrastructure in general. There's a big conversation happening around the world about, in this age of digitalization and AI and social media, the ways in which we've grown distant, and that allows us to dehumanize each other, or only to partially humanize each other. We know our 140 character cells or 280 character cells. We know our digital avatar on social media. You deal with a different distance. A lot of the indigenous communities, I understand, like where I grew up in West Africa, live far from the hospitals And I want to ask you, have you tried to bring people together face to face because you're trying to overcome that distance so that there is the chance to see each other's humanity before there's a crisis? And if so, can you give some advice to some of our technology startups and trillion-dollar net worth companies, and as they think about social media in this age? Your laugh is universal. We all understand it. So.
O que foi falado? Então, todas essas construções foi justamente com o objetivo de podermos fazer a confiança aparecer, surgir, brotar, crescer, nascer em um território tão árido como é o da biomedicina. É aquilo que eu falei no início, já existe uma relação de poder. A biomedicina já está institucionalizada. A medicina tradicional indígena está ganhando espaço aos poucos. Muitas vezes, nós temos que ser esses agentes, porque o trabalho que eu procuro executar não é somente um trabalho relacional, não se limita só a um trabalho relacional para se poder gerar confiança. É também um trabalho de ação política dentro, porque você fazer essa união, fazer esse convite em chamar o DICEI de 2 estados do Brasil, para junto com a diretoria do hospital e lançar essa proposta de fazer toda essa estrutura para que as famílias indígenas se sintam mais confiantes no sistema de saúde, muitas vezes é você que tem que realmente ir ali corpo a corpo, frente a frente, para as pessoas sentirem que você está falando sério, que isso realmente é real e é verdadeiro e que é possível, se todos nós nos empenharmos. Então, eles trazem isso. E, às vezes, a gente até chama, inclusive, mulheres indígenas que estão ligadas a outros movimentos de mulheres indígenas locais para também estar com a gente, isso quando eu estava no hospital com elas, para que elas possam também trazer as demandas das mulheres. Elas falam também. As enfermeiras que trabalham com a saúde indígena também trazem isso também. É para fazer uma grande construção. E é uma construção contínua. Porque, por mais que a gente diga assim, não, agora está feita a estrutura, mas a gente vai encontrar mais adiante um desafio que nos provoque a fazer uma outra alteração, um outro melhoramento, para poder fortalecer mais essa confiança. É contínuo, não pode ser um trabalho pontual e vai embora para casa. É um trabalho assim contínuo de tempos. É isso.
Yeah, thank you for that. Ari, I want to turn to you, and then I'm going to open up for questions and comments from the audience. We just heard both Piyush and Adana speak about trust is actually structural. It's actually political. It has to deal with power. As you think about in your work how we build trust, is that resonant with you? And tell us more about how you've, if so, navigated trust in what are some very complex political settings given the conflicts that have affected the communities in which Muso has worked.
Absolutely. Trust is structural. And was it Cornel West? Justice is what love looks like in public. We have to structure how we care for each other into the world. We have to earn each other's trust by those systems of care, right? And I'm so grateful that you brought up the issue of conflict in this difficult moment where we're living in, because it's a matter of great urgency. We're seeing it, right? We're living in a moment of an age of mistrust in a world at war. There's more armed conflict today than at any point since World War II. It is spreading across the planet like a cancer. And who are the foremost victims of armed conflict? It's kids. And this is something that's deeply personal for me, for our whole team, because these are the people we care for. These are our patients. Just a few weeks ago, several villages of our patients were burned to the ground by militants. And 3 of our patients, kids, were killed. They were burned alive in their homes. And we see the headlines, we see the spread of war, and I sometimes feel powerless. It's so easy to feel powerless in the face of war, but what I've learned from our community partners is that we are not powerless. We have so much power in this moment, and we must use it to build different structures. Structures of care and structures of trust that earn people's trust. And so when armed conflict first spread into the communities that we serve, back in 2018, we had launched this massive randomized control trial. We were following over 100,000 people in this research trial, and war arrived, and the people we cared for were being massacred. And so we asked our community partners, what should we do? What do you need from us? And what our community partners shared was simple. They said, we need you to stay. What they asked us for was an enduring commitment. And what they envisioned, what they were striving for, was not a short-term project, not a tent and some bags of rice. They were looking for partnership and structures of care that they themselves would and could lead. So it's what did we do in that situation? We understood from our community partners that the barriers that were affecting them before, that made it hard for them to access care before, went from difficult to lethal. The stakes got higher. They were often the same barriers. And that's what we learned from patients. So those fees that patients couldn't afford to pay, now how much harder would it be for them to pay those fees when they just saw their home burned to the ground, their cattle stolen, their food supplies burned? The road, the distance they couldn't travel to the nearest hospital, how much more dire that situation when that road had landmines on it, checkpoints. People were being assassinated on that road. And so they had the insight to say, what we need is an enduring commitment to a healthcare system that meets us where we are, that overcomes these barriers, and that is actually led by us. And so that is the healthcare system that we designed with our community partners, that was led by local healthcare providers, by community health workers from the communities they serve, who earned the trust of their communities by being there, by showing up in the ministry of showing up, by showing up even in the middle of the night whenever they were needed and meeting patients where they are. And what happens when we build that kind of trust? We were very worried. We're scared in the midst of this conflict that child deaths would skyrocket, because this is what happens around the world. For every death we hear in the news from direct violence, there are 3 hidden deaths from infants that are cut off from medical care and nutrition because of war. So we were worried that, as in much in the world, when this armed conflict arrived, that child deaths would triple. But our community partners were not seeking relief. They said, we don't want relief, we want equity. Our kids deserve the same shot of surviving childhood as anyone else. And that's what we're going for. And that is, in fact, what they were able to achieve. With our enduring partnership and with their leadership, they were able to reduce child deaths by 63% in 3 years compared to peacetime. Kids were 2/3 less likely to be malnourished in the middle of an escalating war than they were in peacetime before. Child deaths became rare. They made it so because they designed together with us and built a system that was worthy of patients' trust. And that's what we need to do. It is, in fact, it's both human and it's structural. And that, in fact, has been not the end, but the beginning of this story, because our whole world needs to learn from what our community of partners achieved, the largest and fastest improvement in child survival ever recorded in an armed conflict zone. The whole world needs to learn about it. And we see it happening now. The Malian government, despite all of these obstacles, simultaneous incursions by multiple different militant groups, more than a decade of continuous armed conflict, and yet in the midst of this, the Malian Ministry of Health has rolled out some of the solutions we tested together with communities now to more than 6 million people. So the solutions are here. We can build them. When we can listen deeply, we get clues. We can understand what the future of healthcare could look like, what it looks like to build healthcare systems that cannot be broken by war.
Thank you to each of you for sharing that. I'm going to open up. You could just raise your hand, and even if you might raise your hand later, just raise it now. So what we're going to do is get 2 questions at a time so that we can get as many answers. You could either just say to the full panel or specific person. That would be useful, please. And say who you are and your affiliation, just so the panel gets to
Eu vou falar português.
Say it again.
Eu vou falar português.
Ah.
Você vai ser traduzido também. Eu respeito também, eu falo. Meu nome é Ricardo Gorodis, eu sou um argentino com coração brasileiro. E eu me formei em medicina. Estou muito emocionado pela discussão. Você me fez lembrar quando eu faz 40 anos me formei no hospital de infecções. Tinha uma mãe com uma criança com herpes zoster muito grave. Eu fiquei com ela eu sempre adorei falar com as pessoas. Então, ela falou, os doutores não deixam trazer a nossa mulher na comunidade que pode curar ele. Depois disso, e por isso a criança não a melhorava. Eu acho que trust in health, acho que a cultura ocidental, da medicina ocidental, fez crises com isso. Perdimos a confiança na sabedoria das outras culturas e na sabedoria das pessoas. A medicina invita os pacientes a deixar o seu corpo biológico nas mãos dos médicos e que eles vão lutar contra a morte. Então, a concepção da enfermidade está quebrada. E acho, e aqui a pergunta, porque eu me formei como psiquiatra comunitário, também depois me formei em psiquiatria, Salvador Célia, no Porto Alegre, psiquiatra comunitário, que ele me ensinou a acreditar nas forças das comunidades. E aí conhecer a sabedoria dos outros. Então, a minha pergunta também direita, se vocês não acreditam que pessoas como vocês têm que ser maestras para fazer a colaboração, é a palavra mágica desse Skoll. Como que a gente pode colaborar uns com os outros? E acho que a medicina, para arribar para os sucessos, que confiança não é a confiança dos pacientes no sistema, é a confiança dos médicos e do sistema e o respeito pela sabedoria dos outros. Então, como é que vocês nos projetos, e parabéns por Skoll.org, o seu projeto maravilhoso para erradicar os problemas por tráfico, que é muito grave nas grandes cidades. Mas, como eu sou médico, fiquei com a formatura dos médicos como uma das coisas mais importantes que a gente tem que fazer e a gente tem que aprender da sabedoria dos outros como a sua.
Thank you for that comment. Well appreciated. Other questions or comments? Yeah.
Hi, everyone. My name is Muso and I'm the founder and CEO at Safe Mother Alliance. Thank you for this great panel. I've truly been touched and learned a lot from this. So we sit at the intersection of advancing maternal health care in rural areas and low-income communities. I'm a civil engineer turned social entrepreneur when I myself went through the struggles that women living in low-income communities faced when they were pregnant. And it's one of those issues where when you see it once, you can't look away and forget about it. And I have spent the last couple of years trying to figure out this problem of how do we increase access to pregnant women. So in our model, we work with community-based providers who are traditional birth attendants. We train them and upskill them and provide them with the materials that they need to ensure that if it's a home birth, it's a safe birth. Because in our sub-Saharan Africa, almost 50% of all births happen outside of a health facility. So my question is, many models, they build deep trust at a local level, but they struggle when they're trying to scale up regionally or nationally. In your opinion, how do we do this? And I know, Dr. Raj, you're a moderator, but I'd love to hear your insights on this as well, because I know you've been able to do it at Last Mile. Thank you.
For that question. Yeah, maybe Ari, you could speak to that, given your work in a moment. Was there another hand here? We probably have time for one more round of questions, so if you're eager to jump in, or we might not even have one more round. So if you're going to raise your hand now so we get a third person, and go for it, please.
Hi, my name's McKinnon from WotC. Thank you for these beautiful stories and sharing learning. Ari, you started to touch on this looking at conflict and working in conflict, but I'm even extending beyond that, the moment we're in right now of massive mistrust with the changes in foreign aid, technology that feels like it's moving too fast and isn't human. How are you building trust right now, or even more importantly, rebuilding trust?
Great. And that's to the whole panel?
Yes.
Yeah. Great. Any others before we turn? Yep, one more, and then I think that'll be our last.
Hi, my question is about how we can connect the last mile to the fast mile, which actually kind of integrates your model with Piyush's model.
Yeah.
So I'm sure you're familiar with Riders on Demand, right? Uber, blah, blah, blah. Is it possible to train community health workers who could be trained on ACLS, BLS, and who could, on demand, be able to provide services such as the life-saving that was required to help save your cousin, was it? Nephew, I believe, yeah? Is that type of a model possible? And if so, what would it look like? And what needs to be done to enable it?
Thank you. And maybe Piyush, you could take that one. So why don't we turn, Ari, first to the question that came about helping mothers and children during the time of birth and around birth, and how do you scale it?
Mm-hmm. Well, thank you for the amazing work that you do, and for this great question. I think a core theme that we've heard throughout this conversation is that a breakdown of trust at its core is structural. That when patients mistrust the healthcare system, they often have good reason to do so. And therefore, solving it involves both a deep stance of curiosity and learning from those who mistrust, and then that learning should uncover the structural barriers and then invite us to do the amazing work that my colleagues described of pursuing relentlessly a structural solution like the Good Samaritan law in India. I believe that at the core, we can learn and map out, together with patients, what are those structural barriers, and then design with our government colleagues, public sector colleagues often, who have the mandate to reach everybody, what do those solutions look like at a large scale? So and so it involves perhaps recruiting and training amazing trusted providers from the communities that you serve, and integrating them into the health system. It involves overcoming geographic barriers by meeting patients where they are. It involves having the right kind of perhaps emergency transport and removing financial barriers to care. So those structural barriers are happening because of how the health system is currently designed. And that means that we have an opportunity to redesign the healthcare system to remove the structural barriers. And I think that relates also to this question that McKinnon raised. Thank you also for the amazing work that WOTC does. Because mistrust, we know how fast misinformation is flowing in this age of mistrust, right? And what is the oxygen that misinformation breathes? Lies take on a velocity because they're rooted in something, because people feel betrayed, right? So we've got to earn back people's trust through what we do. I believe one of the number one ways that we can do that is removing out-of-pocket fees for care, which is something that WOTC is a big part of. Because right now, 1 billion people are being driven into poverty every year by healthcare costs. And why should patients trust a system that is impoverishing them so frequently? And we can overcome that by design.
Thank you. Piyush, yeah, and feel free to respond just because we're short on time to any of the other ones, and then we'll have Adana give the last word.
Sure. Just very quickly to add to what Ari was mentioning, I think the challenge has been with the current form of health systems is that they are designed around what we expect people to do, how they should behave, how they should approach the system, how they should come prepared for it, and so on and so forth. And I think the rethinking that has to be done is that instead of that, if we started looking at what their fears are, what their challenges are, what their mistrust is because of, I think that's where you start seeing the solution at scale emerging. So, all the things that we've seen with vaccine hesitancy, with emergency responses, with various failures that have happened. The challenge has been that it is only after we have looked at what those areas of mistrust were and sought to resolve them is where things have happened. So what I wanted to propose as part of this panel is that, can we have, before every major health investment, shouldn't there be a trust diagnostic that actually takes into account the current status of that specific community's fears, failures, challenges, and builds that system taking that into account. Now, when you're building physical infrastructure, you do load-bearing assessments. And if trust really is core infrastructure, why should we not do an assessment,
trust-bearing
for that? Yeah. So that's something that I feel is,
I love that.
Something that has to be instituted with every major investment that
I love
comes through.
that. I love that. Adana, any final comments? And the answer to your question is yes, just so you know. And just to make sure we don't leave you out. But Adana, any last words and any responses to questions and any last points you wanted to make? Just noting we're short on time, so if we could be brief.
São 4 perguntas, né? E não dá tempo para responder a todas, né? São,
Yeah.
e
Any one you would like to. Yeah.
E todas exigem mais tempo, mas assim, só para concluir, né? Para resumir, nas áreas de saúde indígena, nós já temos nossos agentes de saúde indígena, onde são pessoas da própria comunidade que já passam por uma preparação para ter esse trabalho com a equipe multidisciplinar, que tem um médico, dentista, uma equipe. Então, nas áreas de saúde, existe a própria pessoa indígena, que é um agente de saúde indígena, e tem um agente de saneamento indígena. Então, eles estão ali conectados, né? Estão ligados e moram na comunidade e fazem os primeiros atendimentos no sentido de primeiras contatos, né? Questão de saúde, medicamento, etc. Eles levam as demandas para os médicos e os médicos fazem a visita nas comunidades. Então, existe alguma coisa assim já estruturada. Inclusive, existe, como lá nossos rios são nossas estradas. Então, tudo é feito por barco. Nós temos as nossas canoas como fosse velozes, que nós chamamos assim, bem velozes para poder chegar nas comunidades e levar as equipes. Então, de alguma maneira estruturada, vem se conseguindo, inclusive, através dos DCs, que são esses 34 DCs espalhados no nosso país. E com relação a essa questão assim da confiança, tudo que foi falado aqui é extremamente importante. Tudo aqui constitui o que nós poderíamos falar sobre a confiança, que não é só relacional, é estrutural, também é questão de posicionamento político dentro das próprias estruturas. E é isso, que esses conhecimentos todos que foram aqui compartilhados, inclusive essa questão do respeito. Confiança passa pela escuta, e escuta envolve respeito. Não tem como, é um tripé sagrado, não tem para onde correr, é isso. Então, mediante a isso, mediante a muitas lutas, eu fiquei extremamente contente. Eu quero compartilhar isso aqui com vocês. Isso aqui no meu país saiu dia 6 de abril, faz 17 dias. Isso aqui é histórico. Os conhecimentos nossos, nós povos indígenas, não eram respeitados pela medicina científica oficial, muito menos dentro de hospitais, postos de saúde, pronto-socorros. Mas agora, com essa portaria que saiu dia 6 de abril, faz 17 dias, marca assim, algo assim histórico, porque é um reconhecimento oficial dos saberes indígenas pelo Ministério da Saúde. Saiu uma portaria para nós, o 10.676. Esse 10.676, ele é uma portaria. Gente, isso aqui é histórico. Pela primeira vez, meu país está reconhecendo que nossa medicina tradicional indígena, ela também tem a mesma validade, o mesmo poder. Eu faço questão aqui de ler, é muito breve, não quero tomar mais que o tempo, mas que fala assim, o reconhecimento oficial dos saberes indígenas pelo Ministério da Saúde. Um dos objetivos centrais da portaria é promover o diálogo intercultural, incentivando a atuação conjunta entre especialistas indígenas e equipes multiprofissionais do Sistema Único de Saúde, ao reafirmar a importância das medicinas tradicionais. A norma estimula práticas colaborativas e o reconhecimento de diferentes sistemas de cuidado, ampliando o alcance das ações de saúde e valorizando os saberes locais. De fato, representa uma mudança de paradigma no reconhecimento institucional das medicinas indígenas e de seus especialistas no âmbito da Política Nacional de Atenção à Saúde dos Povos Indígenas e do Subsistema de Atenção à Saúde Indígena. Esse movimento não apenas valida os saberes ancestrais, mas também sinaliza uma abertura para compensar o modelo biomédico hegemônico a partir do diálogo intercultural, aproximando Estado, comunidades indígenas e profissionais de saúde em busca de um cuidado verdadeiramente intercultural. Isso é histórico. E eu estou muito feliz com isso.
It's a new take on AI in healthcare. It's not artificial intelligence, but ancient intelligence being used to, Well, I can't think of a better note to end on. Thank you, everyone, for being here, and thank all of our panelists again for their awesome work. Thank you.